along with my co-panelists today as we discuss racism as a public health issue. I am thrilled and honored to have such a diverse panel. We're all looking forward to having this discussion with you all. So we're just going to take a moment to introduce ourselves. So we're going to start with Reverend Dr. Sandra Connor. Would you please introduce yourself?
Good afternoon, everyone. I am Reverend Dr. Sandra Connor. I am a pastor at Sehpard Missionary Baptist Church. I'm also a deputy director at Maryland Faith Health at Maryland Citizens Health Initiative. I am the president of the Baptist Ministers Night Conference, and I'm delighted to be a part of this conference here today.
Awesome. Thank you so much, Reverend Dr. Connor. Next, we'll have Senator Mary Washington.
Great. Good afternoon, everyone. I'm so honored to be a part of this very important and timely conference. I am State Senator Mary Washington. I represent the 43rd Legislative District, Baltimore City. I served as 8 years as a delegate before I ran to become the state senator. I've been the state senator for the last 2.5 years. I serve on the Education, Health, and Environmental Affairs Committee in the Senate, and issues around health and healthcare, and particularly around the profession of healthcare providers comes to our committee. I'm also the Senate chair of the Joint Committee on Ending Homelessness and the Joint Committee on Children, Youth, and Families. I'm so honored to be a part of this. Also, why I want to participate in this conference and why this issue of health and public health approaches to all of the challenges that face our communities is that I have a PhD in sociology from the Johns Hopkins University and with a focus on public health. So just honored and so honored to be with all of you here today.
Thank you so much, Senator Washington. Dr. Michelle Gourdine.
Good afternoon, everybody. My name is Michelle Gourdine. I am a physician, pediatrician by training, with a long background in local and state governmental public health, most recently in my public health stint, serving as Deputy Secretary of Health for the state of Maryland. I'm also a speaker and an author. I wrote the book, Reclaiming Our Health, A Guide to African American Wellness, which was published by Yale University Press back in 2011. I have been privileged for the last 3.5 years to serve as Senior Vice President for Population Health and Primary Care at the University of Maryland Medical System. This is a system in Maryland of 13 hospitals across the state. I also serve as Interim Chief Medical Officer of the University of Maryland Medical System. I agree with all of my co-panelists. I am delighted to take part in this important conversation and look forward to interacting with everyone.
Thank you so much, Dr. Gourdine. And I am Nicole Rochester. I am also a pediatrician by training, and I left clinical medicine about 3.5 years ago to become an independent health advocate. I am the CEO of Your GPS Doc, which is a company that helps patients and their family caregivers navigate the healthcare system. I'm also a speaker, an author, and a health equity consultant. And I've had the honor of working with the Maryland Patient Safety Center and the Maryland Hospital Association over the last year with projects related to health equity and medical racism and health disparities. So it is truly my honor to have this conversation. So I guess we will go ahead and get started. For those of you watching, go ahead and feel free to type your questions in the Q&A. And we will address your questions at the end of our presentation. So our first question, many experts are calling racism the next public health crisis. And so we're each going to weigh in and share our own thoughts about this issue, racism being a public health crisis. And I'll get us started off. You know, I think that we can't really discuss racism as a public health crisis unless we acknowledge and understand the history of racism in medicine. And the ugly truth is that, you know, medicine has its founding in racism, really from the inception of our profession. Back in the 1800s, the theories that supported biological inferiority, that literally said that Black people were inferior that Black people were less smart, that their brains were smaller. These theories were developed and supported and spearheaded by medical doctors like Dr. Samuel Morton and Dr. Josiah Nott. Doctors actively participated in the slave trade. Doctors were hired to be at the auction blocks and to literally examine slaves and determine their fitness. We know that there's a long, painful history of medical experimentation in which doctors experimented on Black bodies. We know that the founder of modern gynecology, Dr. J. Marion Sims, did surgery on Black women, Black slave women, young women, I might add, without their consent and without any anesthesia. And it goes on and on. The Tuskegee experiment, forced sterilization, and even modern day examples where Black and brown people continue to be treated without respect in our healthcare system. And so, unfortunately, that is really the dirty truth of medicine. And if we talk about, again, public racism being a public health crisis, and we go back to the health disparities, I trained in the 1990s, and this was well known. They told us over and over again that Black people have higher rates of this and higher rates of that, and we die more from this and we die more from that. And we know that this has been formally documented, going back to 1985, when we had the Heckler report that was released by the Department of Health and Human Services. And that was probably one of the first instances where there was formal documentation of race-based health disparities. And back then, over 30 years ago, it was determined that this was an urgent problem and that urgent action needed to be taken. And yet, here we are. There have been numerous workforce task forces and work groups and committees. We had the establishment of the National Center on Minority Health and Health Disparities back in 2000. This has been a subject of healthy people initiatives over the many decades, and we really have not yet moved the needle. If we go to 2002, the Institute of Medicine released the Unequal Treatment Report, where we finally started to delve more into why these disparities exist. And we began to acknowledge that it's more than just social determinants of health, but that Black and brown people actually receive different care and disparate care, and care that is poor. And so, for all of those reasons, racism absolutely is a public health crisis. It's not acceptable for us to just continue to report year after year after year that, Black women die more in childbirth and Black infants are more likely to die and Black people are more likely to die from cancer. We can't just keep sharing those statistics and not acknowledging what's at the root of the issue. So with that said, I'd love to move to my colleague, Dr. Gourdine, and maybe you can share your thoughts about racism as a public health crisis.
Sure. Thank you, Dr. Rochester. Just to build on your excellent comments, which really do lay a foundation to understand what we're talking about. I think the other thing that's important, actually two things. So, we talk about public health, and my having served in public health for a long time, a simple way to describe what that is to people is it's the responsibility to protect and improve the health of people and their communities. Very simply, preventing disease, promoting health, improving quality of life. So when we look at the reality of the situation and we understand what drives health, healthcare is vitally important. And you pointed out, Dr. Rochester, some extremely important facts that we need to keep in mind in terms of how the healthcare system contributes to health disparities. But we also know that there are other factors, other non-health factors that also play a huge role into how healthy you are or are not. And it has to do with social factors. And we know that based on the history of this country and sort of the embedded thought processes of racial hierarchy, that race actually at one time or another determined where you lived, where you went to school, where you work, whether you have transportation. And that actually translates into persistence into present day. And so what you have when you look at our communities is that there are certain communities that are, predominantly Black, that are socially deprived and that are under-resourced. And the fact that they are in that state predisposes the residents in that community, who are predominantly are all Black, to premature disease and death. So poverty and low education and unemployment and exposure to environmental toxins. You know, when you look at the science behind all of that, you find that minority communities and predominantly African-American communities are disproportionately represented in those categories and disproportionately exposed to that chronic under-resourcing and social deprivation. But I also want to take it one step further. Being a pediatrician, obviously, I'm very concerned about the growth and development of children. We have Black children who are disproportionately born and live in these conditions. And this causes them to grow and to develop unequally compared to their peers. Finally, the stress of living in these situations. We understand now the huge impact that stress has on health. We understand, you know, the food deserts. We talk about that all the time, and the lack of availability in some neighborhoods of nutritious foods that promote growth and development and health. And you really do have an equation, a formula that begins to describe the disparities that we see that were based on the sort of foundation of the thought that there is racial hierarchy and that one race is inferior to another.
Absolutely. Thank you so much, Dr. Gourdine. I just want to underscore what you said. It's just so important about how structural racism has played a role in these social determinants of health and are really the very reason why we see these disparities in living conditions and everything that you mentioned. So thank you so much for pointing that out. Senator Washington, we're going to go to you. What are your thoughts about racism being a public health crisis?
Well, first of all, again, I think this topic is just right on course. And I think your initial points about laying out the historical pattern and historical crisis that is racism. And it's also interesting that it's thinking that it's just sort of coming about, right? That all of a sudden racism, is a crisis. And I serve in a body, so as a state senator, you mentioned the importance of the sort of execution of the profession of medicine, and how fundamentally any innovation that developed was really on the backs, literally, and on the bodies of Black and brown people in this country. And when we think about health policy, which is where I enter as an elected official and as a state senator, serving in a body that was created in 1650, part of the upper house of a colonial assembly, having a constitution that was ratified and what was created in 1838, where senators were starting to be elected for the first time. And then because of a Supreme Court decision in 1972, the Supreme Court set up, that there would be 47 legislative districts. But guess what? It wasn't until 1950 that the first African American was elected to that body. Actually, it was 1954. A Republican, Mr. Cole, he ran unsuccessfully for the House of Delegates in 1950, and then he was finally elected in 1954. And then it wasn't until 1962, the year that I was born, that Vera Wilson, became the first African-American woman elected to the Maryland Senate. So I serve in a body, and I go every year for the last 12 years to Annapolis, and in an institution where just yards away, Black bodies were sold on the auction block, where children were taken away from their parents and sent to Washington, D.C. to build our nation's capital, steps away from a place where women couldn't own property. That was the law of the land. We couldn't vote. We couldn't get credit. Where a man's right to rape his wife was upheld again and again by virtue of marriage. That marriage was restricted by color during the anti-miscegenation laws, by race, by sexuality. And so the very place in which we develop the policies around healthcare are also centered in racist practices and white supremacy. And so an example of some of those sort of assumptions that we still are fighting against, and I'll just wrap up with this. Our Senate committee created a work group to look at the vaccine distribution around COVID-19. And although the governor and the Department of Health were really tasked with the vaccine distribution, like many of you noticed right off the bat, disparities in the distribution model. And so we were pushing to make sure that Secretary Schrader and the administration had an accessible, equitable, and efficient and transparent centralized model. But you all remember, every time any of you as healthcare providers, as public health professionals, as the clergy pointed out the racial disparities in the distribution model, what was it attributed to? Hesitancy, right? It was attributed to, oh, well, Black people don't want it or they don't trust, and didn't look at access issues, didn't look at the fact that there wasn't a phone number and that it was a sign up online and that there's a digital divide, and that this idea of distributing the vaccine based on the population, that we would somehow divide it up evenly, that there's a difference between equal distribution and equitable distribution. And so my comments are just as yours, that until we're really willing to look at the history and the fundamental tenets upon which both healthcare quality, policy, as well as the practice of healthcare is fundamentally racist in and of itself, and that it's not the next public health crisis, it is the public health crisis and has been that way for centuries.
Wow. Thank you so much, Senator Washington. I just learned a lot. I thank you for providing that historical context for, from the Maryland legislature. Yeah, you've opened up my eyes. And I think that ties in so perfectly, in a sad way, to what Dr. Gourdine and I shared. Thank you so much. Reverend Dr. Connor, I would love to hear your thoughts about racism being a public health crisis.
Thank you, ladies, all of you, three of you, for sharing the history perspective, the political perspective about this being a health crisis. And I agree with Senator Washington that it just didn't start. It's been here. It is inevitable. We've been faced with it forever and a day. But for us, from a clergy perspective, it adds a different aspect for us to look at. Yes, we know that there's history of those things that we've got to try to get beyond the hesitancy that causes folk not to get health care. And that within itself causes our folk not to have the right kind of health care that they need. Yes, we know that there are political issues and challenges that we've got to make sure that they're not structurally imposed that would cause us to have situations that will cause there to be disparities. But now what we're faced with is the fact that we no longer, I believe as clergy, can no longer just simply look at it from the standpoint of, oh, well, that's your job, healthcare profession. That's your job, Senator Washington. That's your job, Dr. Gourdine and Dr. Rochester. It is not your job alone. It's our job collectively to partner to come together. We can no longer say to a person, you go home and simply pray. And make sure that all will be okay when you get up off your knees. No, we're going to tell folk that they can pray, but we also got to give them education. We also got to hear this kind of stuff, tell them the kind of things that you share with them today. And then if need be, we've got to also have the resources that we refer people to. We have to deal with people because this is a health crisis that has been here yesterday and will probably be here for a while until we can fix it. But it's one that affects the entire body of a person, the entire mind, body, spirit, and soul. We have to deal with things holistically because when there's racism, everything about you is affected. Your family, your health, your relationships, your job, your community, everything is affected. And as a result of that, we've got to make sure that we as clergy, we as healthcare professionals, we as community leaders as well, have got to pull together to make sure folk get the right resources to get beyond it. We're traumatized. I don't know about you, but if you think about it, this racism is growing so much so. Yes, not only we've had it for a while, but now it's become a traumatic situation where we are, well, let me speak for me. I'm becoming somewhat traumatized when I hear and see the kinds of things that are going on. I don't know when the next move is going to be made by some of the folk that are in, well, let me shut up and let me move on. But that's my 2 cents worth for now.
Yes, thank you so much, Reverend Dr. Connor. And yes, we are all traumatized. I raised my hand. I'm sure the co-panelists feel the same way. This last year has been like no other, and it's really, it's coming to the forefront for everyone else. The country at large. But like all of you have said, this is not a new problem, and this certainly did not start today. And I appreciate, Reverend Connor, that you mentioned the value of partnership. I think that we've seen that so much during the COVID-19 pandemic, and these partnerships between faith-based communities and, healthcare institutions as it relates to testing and now with the vaccine distribution. And so, we can't underscore that enough. We can't do it alone. You all can't do it alone, so we really do need to take advantage of these partnerships. I just want to remind those of you who are watching, if you have any questions for us, please feel free to put those in the chat box and we will address those at the end. So we're going to move to our next question, ladies. The question is, how do we start breaking down the barriers that uphold racial inequality through policy decisions? So we're going to start with you, Senator Washington.
Okay, hi. So thank you for your patience. So whenever I have a panel, I make sure that I try to do a little bit of research and making sure that I'm up to date. And I said, well, what is the CDC saying about this? And right off the bat, the CDC says racism is a serious threat to public health. So I think the first thing that we could do to break down the barrier and uphold racial inequality through our policy decisions is accept that. Too often there's still a bit of debate about it. So if we just accept it as a reality, and then we can begin to, as policymakers, work towards ending it and breaking down the barriers. There's been a little bit of a backlash, and I think you all have seen it, where we make these assertions, we continue to make these assertions, it's been demonstrated time and time again, and then there's a defensiveness that is developing around being really invested in displaying the ways in which a particular institution is not a part of the problem, or just sort of talking about all the good things that we do in the communities. All the mobile vax units that are now being set up, not talking about the research that has been done in communities about the denial of healthcare, but focusing on the number of community associations that you attend, or the amount of money that you give to different organizations. So I think once we do that, as our large institutions that are in Maryland recognize that then we can move on. But then we can be really specific. This session, I and the General Assembly passed a number of measures that I think can begin to address and as you say, uphold racial or breaking down racial inequality. So I passed legislation to improve the health department's outreach on cognitive impairment and Alzheimer's and types of dementia. So I see nodding. We know that cognitive impairment and Alzheimer's and that there are types of dementia, and I think add that to stroke, that still there's a disproportionate impact on our communities. So this legislation is specifically coordinating a partnership with the Vivian Jones Alzheimer's Disease and Related Disorder Council, the Alzheimer's Association, and the Maryland Department of Aging, and having a focus on Black and Latinx communities to really get the word out about treatment there. We really need to improve funding and support of Medicaid for Medicaid recipients, and allow Medicaid recipients to be reimbursed or for Medicaid to be reimbursed for a full range of behavioral health related services. There has historically been a tendency to have greater criteria, or to not support or to not reimburse for the full range of services that can be offered. So there's a disparity between individuals that have private insurance and individuals who have state or federal insurance. Specifically, I passed a bill around ensuring that the best practices and behavioral related services related to autism are there. So again, that's a disproportionate impact on Black and Brown communities. Bereavement. I recently lost my mother, but the issue of bereavement and taking time for that and seeing the degree to which that, the need for that type of support is something that we can do and support families, making sure that they have the medical, we've ensured that you have the medical leave to take care of a loved one, but we also need to look at the end of life. And then also looking at pregnant and parenting women. We passed a bill to extend postpartum benefits for Medicaid recipients from just 2 months from postpartum to a year, and then also to include dental care. So I think just having a race equity lens on every single policy decision that we make, and ask the question, is this disproportionately benefiting non-white people? Is this disproportionately harming Black and Brown communities and low-income communities? And that is our position.
Thank you so much, Senator Washington. I think it's so important. Everything you said was incredibly important, but I really want to highlight the last thing, which is using that equity lens to every single thing that we do. And that's definitely important and key when it comes to policy. Dr. Gourdine, what are your thoughts about policy and breaking down these barriers?
So first of all, Senator Washington, I just want to thank you because, what we understand about systemic racism is that the reason it has been persistent over all of these years, these decades, these centuries, is because our policies and our societal practices reinforce it. And so I'm a firm believer in the way that we change that is to take a look at our policies. So I'm so appreciative of you and your colleagues who are placing that lens on our policies and practices, because that is going to drive the change that we need to see, I believe. I want to piggyback also on something that Rev Dr Connor said. She talked about racial trauma. And I want to just land there for a moment, because in addition to the policies, the practices that have been systematized and have existed over time to create these conditions that create poor health in African Americans, I also believe that, when you see things like, for example, these police killings, and let's just take the George Floyd, and I'll be the first one to admit, I have not ever watched the entire 8 minutes, 40 seconds, it's 9 minutes and whatever seconds now of that video. I cannot do it. I cannot do it. It is too traumatizing. The reason I believe it's traumatizing to many of us, and not only that, that is one of too many examples over time of trauma, is that it reinforces and it puts in your face again and again and again the notion that society values us differently, that we are less valued, that we are dehumanized. The way that man was treated, no human being should ever have been treated for any reason. And then when you hear from people, well-meaning or not, who say, well, if only he had just done what the police said, there is no excuse to treat another fellow human being in that way. When you get those messages again and again and again, that we are socially devalued, and then if you are like me, a mother, or if you are an aunt or a friend or whomever of young boys, and you have to teach your boys that, listen, I know you are a good person. However, there are people you are going to run into that because you are dark skinned and you wear a hoodie, they are going to have differential assumptions about your intent that will be negative, and that may risk your life. And therefore, you need to respond in a way that protects yourself. That's traumatizing. All of this is traumatizing. So you've got these differential assumptions that occur. And this can even extend into healthcare, where we see a patient, we make an assumption. I have an example. I'm not going to give the particulars of it, but in my own family, of an individual who recently sought care, who is a very, wonderful person. But because, quite frankly, of her race, she was treated unfairly and inappropriately. Because people make differential assumptions about you based on your appearance. And the whole idea of race, Harvard, and I wrote this down, Harvard defined race, I think, very, very succinctly and very accurately. They said it is a system of structuring opportunity and assigning value based on the social interpretation of how somebody looks. And that's exactly what happened to my family member when she went in to be treated. A differential assumption was made about her, and she was not a recipient of the type of health care that she needed to receive. This happens again and again and again, message after message after message that says you as a Black person in this country are devalued. So we must work in order to counteract that, to change that. Policy is vitally important in changing that. We also talk about things like diversity and equity and inclusion. These are not taglines. These are actually things that need to happen. When we talk about inclusion, what we're talking about, in short, is allow us to exert our innovation and our talents and bring our talents to the table. Allow us to be seen and heard fully, not based on someone else's interpretation of how they think we should be, not saying that we need to fit into someone else's interpretation of what's normal or abnormal, right or wrong. We are right. We are normal. We bring great value to the table. The fact that we are ourselves and our uniqueness means that we have something to offer to an organization, to a community. That's what inclusion is all about, fully seeing me for who I am, not expecting me to adapt, not expecting me to modulate, not expecting me to not show emotion because I don't want to be seen as an angry Black woman. None of that. See me for who I am. Let me be who I am. That's inclusion. That's how we begin to address this racial trauma that we are seeing. And that's how we begin to address these issues that are driving disparities and inequities in healthcare.
Absolutely. Thank you so much, Dr. Gourdine. Both you and Senator Washington have really highlighted the importance of policy and how, as you stated, it's the policies that perpetuate these inequities that we see. And I just want to piggyback off of something you just said towards the end about DEI, or diversity, equity, inclusion initiatives. And certainly with the death of George Floyd and all of the other deaths and trauma, there's been this sudden resurgence or sudden appreciation, as you mentioned, Senator Washington, about racism. And, many of us, I'm sure you all did too, received emails from our respective organizations and, emails from retail establishments and restaurants, and, everybody's saying that they stand with us and, we're committed to this, we're committed to that. And suddenly pictures on websites started to look more diverse. But it goes beyond that. This is way beyond putting a picture on your website and grabbing your one Black, your one Latino, your one Asian, employee and putting them all in the room together and taking pictures, and so to get back to this idea of policy, we are not going to move the needle with health disparities until we address policy. Specifically, you mentioned about, being seen and being appreciated in the workplace. And so as it relates to healthcare, we need to look at our hiring practices. We need to look at how we recruit the people that work in our healthcare facilities, and where are our sources for recruitment? Are we actively looking at the historically Black colleges and universities, as an example? When we say there's just nobody there, there's no talent, where are you looking for that talent? And then once we recruit and hire diverse applicants, are we nurturing them? Are we mentoring them? Are we making sure that they have access to the knowledge that, you know, many of the other executives have? You know, are they being left off of the golf course, as an example? Are they aware of the opportunities for advancement? And specifically within, you know, the physician workforce, we know that only 5% of practicing physicians are Black. And that number has not changed for decades. And if we look at Black men, less Black men are applying to medical school now than in the 70s. So, you know, this is unacceptable. So we have to look at the policies around medical education and medical school admissions and the criteria that are being used. And as you all said, are those criteria disproportionately impacting Black and brown people? You know, do we need to? And I'm not saying, we're never talking about lowering the bar. You know, we're not talking about having people be invited to attend medical school or promoting people to positions for which they're not qualified. There are many qualified people out here, but what are we doing to actively recruit and retain and develop that talent? We have data that shows that Black patients receive better care when they are seen by Black doctors. Now, I can't even imagine if that were turned. You know, if there was data that showed that white patients get poor care from Black doctors, all of us know what the implications of that would be. Yet we have solid data that shows that Black and brown patients have worse outcomes when they are seen by non-Black and brown physicians. And so one of the ways to address that, other than dealing with the bias, and, you know, is to increase the pool of Black and brown physicians. And that's extremely important. So Reverend Dr. Connor, from a faith-based perspective, I would love to hear your thoughts about, and you started to talk about this earlier. What do you think what is the role of church and other faith-based organizations in breaking down these barriers that perpetuate racial inequality in healthcare?
Thank you, Dr. Rochester, for asking that question. Thank you, co-panelists, for the wealth of information that you've shared. And what I appreciate most is the fact that you shared it with passion, and I've learned some additional things. I really appreciate the thought that you said, Senator Washington, the fact that you are using an equity lens as you put out policies. And I'd like to share with you that I'm working with Benny DeMarco at the Maryland Citizens Health Initiative, and we have a racial equity committee, and we are looking at all of our projects from the standpoint of whether or not it meets that. So much so that as you were speaking, it dawned on me, maybe that needs to go beyond just policymakers. Maybe needs to go beyond community persons who are doing things. Maybe we all, because see, racism does not just happen amongst Black and white. Racial issues and discrimination is in many ways and many opportunities for it to happen. But let me go back to the actual question that I've been posed to answer. Oftentimes people say, what are the faith leaders doing? Churches and pastors not doing anything. I beg to differ. It may appear that we're not doing a lot. It may appear that we haven't done a thing, but I beg to differ. Well, I can speak for myself and some of the others that I've worked with that I do beg to differ. And I guess I've noticed and watched a paradigm shift. I got in healthcare like 5 years or so ago, coming out of a communications background and education background and other kinds of background, but happened to land an opportunity with Benny DeMarco. And we started back in 2015, an opportunity that's called the Maryland Faith Health Network. That particular initiative was designed for us to work with hospitals, to have hospitals call the faith leader to let the faith leader know that their member is in the hospital. The whole purpose for that was to get the faith leader to know in advance that the patient is in the hospital, that he or she might begin some wellness initiative to get their member back up to speed and back back into service. Also, it's an opportunity for us to be able, as a faith leader, to be able to monitor what's going on with our congregant. So that was one of the projects that we did for the Maryland Faith Health Network. We began to get over 70 churches were involved in that over that period of time, where we began looking at health ministries. What were they currently doing? We tend to look at health ministry just simply be, take 2 aspirins here. I'm going to send you a scripture, send you a book. I'm going to send you a poem. No, that's not what we're doing now. We're trying to expand it beyond that. So much so that you now have us looking at, in some instances, community health nurses and parish nurses and things like that are now going on. The faith industry is now, and I called it industry. I don't know where that came from, but it came out my mouth, my belly. But the faith now has a different role and a different perspective, where we're now looking to do more things, because we do know that we are a trusted group of folk where people can come to. We do know that we have access to people that will listen to your policies, Senator Washington, when you put them out there. We do know Dr. Gourdine and Dr. Rochester, if you have an information that you need to get shared, that we are in the position that we can share that information, that we can give it to them the way it ought to be. We do know that we have lots of people that we can get to easily, probably more so than you can. And many instances. How do I know? We went through the situation. University of Maryland did this operation, Get Out and Get Vaccinated. We looked at the situation of there being a vaccination shortage, and we were able to work with the faith community and University of Maryland medical system to begin in the hot spots of West Baltimore, where there were serious problems going on. That was a huge success for, as far as I'm concerned, because not only were we able to get the vaccination shots out, we're able to try to get rid of dispel some of the myths that people had, as well as I actually had one of my members, he was actually a captain of a whole apartment building, running around, becoming an ambassador to get people shots. It began to show communities coming together and to do things to make a difference. So those are kinds of things that we're doing from that aspect. But what is our role? One is to be a faith leader, to share the faith, to bridge the gap when it comes to ministry, things that are related to the spiritual side of that person, but also now to look at that person from a holistic perspective. Mind, body, spirit, soul, education, whatever it needs, to look at them and provide resource. We're not the be all to everybody, but we ought to at least begin to look at it from a holistic perspective, making sure that we get the right people in the right place. We're also becoming more involved and engaged when you, for example, Dr. Washington, Senator Washington, put something out, a bill or something, to be a part of your rah-rah person to say, yep, we agree with it. We're also the one to say to you, Dr. Gourdine, what kind of funding or resource do you have to help us to promote and get things done? So we're looking for all kinds of resources to try to get our projects moving and moving forward. We're thinking outside the box. We're no longer looking at the way we used to do things. There used to be a stigma where church and state was kind of like a no-no. That has dissipated. I think we're looking more to do more partnering with other community-based organizations, more state and local government, because we know that we are not an island unto ourselves. We know that we have the stuff, if we all work together, that we can indeed make a difference to do what we need to do. And so I know we're running out of time, so I'm going to wrap this up. Some of the things I think that we can do is, one, be coalition minded by building community empowerment. We have to empower our folk, empower them by giving them the information. I see what somebody wrote in the chat box. Thank you for that Harvard definition. Give people the information, let them decide. Let them decide what they're going to do and how they're going to do it. Don't hold back, and get them engaged and involved. Let them tell you what they need and what they want. Let's not always tell them you need this. And I believe that it'll make a big difference, and we'll be able to remove some of the barriers that we're dealing with and facing. We can do this if we do it together. The word of God says, when did you not feed me, clothe me, or whatever? When I was in prison. I'm not going to give you the whole scripture because we ain't in church now. We're going to move on. Amen.
Amen, Rev Dr. Connor. Thank you so much. I really appreciate your comments. And, the Black church has always been the bedrock, right? I mean, the civil rights movement, all change really that has happened as it relates to inequality in our community has really started in the Black church. So I think we basically need to get back to our roots. Before we do our closing statements, I just wanted to go through a couple of the questions. And for those of you watching, first of all, thank you again for joining us. I hope that this conversation has been enlightening for you. And please feel free to type your questions in the box. We have a question from Riley. With the compounding traumas of the past year, what plans are there to increase needed counseling services to BIPOC people? I think I'm going to turn this one over to Dr. Gourdine. Dr. Gourdine, can you speak to that maybe within the University of Maryland system?
I can. I mean, this is an issue that healthcare recognizes that we are speaking about under-resourced. We're under-resourced in terms of providing those counseling services by professionals to address these types of issues. We are looking at innovative ways to provide that type of counseling service. We're actually looking to those areas that we serve that, for example, they may be in rural areas or other areas where there is a deficiency in the number of providers who can provide that counseling. How do we partner? To Rev Dr. Connor's point, how do we partner with others in the community who are providing these services, even including the health departments, for example, to go out hand in hand, make sure we outreach and provide these types of services to individuals. We recognize that not everyone has access to broadband Wi-Fi services in Senator Washington. That's something that we need to address as well. But for those who do, how do we use telehealth, for example, for individuals who where we might have the personnel, let's say in Baltimore, but the need is over in East, as opposed to having people drive across that bridge? How do we connect them using technology? So we're looking at all of those things. But I appreciate the question because, one, the services are needed to address the trauma that people face. But secondly, we also understand, especially in our community, there's a lot of undiagnosed mental health issues that need to be addressed as well. And so there's a lot of work that needs to be done. I'm not going to take up a lot of time, but I want to acknowledge the need and provide some examples of some of the things we're doing at the University of Maryland Medical System to address it.
Can I also let you know what's going on from a faith perspective? We are recently, we just finished up some training called Healing Us Together. That's a Johns Hopkins initiative that's working in conjunction with the Baltimore Behavioral Health System, where we have trained several clergy, where we have learned how to not necessarily treat traumatized persons, but to begin to identify, to begin to let folks see and realize that there might be some stuff that's impacting them, affecting them, and not allowing them to be able to go across the street or get to the next point that they want to go. So there are lots of initiatives that are going on to allow folk to begin to think about the fact that, first of all, yes, I'm trying. It's almost getting help is a mission. You got to admit it first and foremost. And so Healing Us Together is one of the ways that we hope to be able to get as much coverage as we can within this the 14 districts within Baltimore anyway, try to expand that. And we just initially started that, and hopefully we'll be able to get to some different areas going very soon.
And Dr. Rochester, if I may, I believe in, and I absolutely support what Dr. Gourdine is saying, but we also need to just have walk-up counseling centers on every corner. I mean, we need to have storefront walk-up centers, and I do believe we have the infrastructure. We have what our community action centers, but now they're used mostly for weatherization, and so we could really, and this is statewide, we can utilize these institutions, these for people to just walk in. They don't have to set up the appointment. Telehealth is absolutely helpful, but someone just might be walking down the street or someone need to say, look, you need to go and talk to somebody. They really can. They can just go to the corner, because we also have to reduce the stigma, right? So the stigma associated with asking for help, getting past that, what my mother would say, and I know probably some of you have heard it, but you're too black and poor to be depressed. You need to get up and go to work. This idea that we have to go through it no matter what, and understanding that the repression of that holding of that back hurts our health. but that stigma associated with not being Superwoman, that's still there. And to normalize it, that you're just walking in the corner and you're going to go sit and talk with somebody who is a trusted person, who is a member of a community, and who fully understands that. So I guess, Riley, we don't have that yet, but I think specifically to address that is that we need to have walk-in counseling centers based in communities where people can get the help that they need.
Wow. Now that's innovation. I love that. And that's what it's going to take. I mean, we are going to have to think outside of the box and come up with creative and innovative solutions. So thank you, all of you, for weighing in on that. We have another question that actually ties in. It's time for us to wrap up. And our wrap up question was going to be about next steps. So Brandon, thank you so much for your question. Brandon says, thank you for the great insight and discussion. Understanding that racism is a multifaceted public health issue, what tangible steps should organizations take to ensure they are not perpetuating or contributing to this public health crisis? So, Brandon, I will start by, first of all, thank you for that question. I think that, it's nice to have these discussions, but we always want to leave you all with something tangible that you can do. And what I would say is, for those of you working in healthcare institutions, one of the first things that you can and should do is to review your data by race and ethnicity. Look at your outcomes, look at the health outcomes, and break them down by race and ethnicity, so that you can begin to have an understanding of the disparities that I'm sure exist in all of our institutions throughout the state. So I think that's the very first step, is that will give you an understanding of the depth and the breadth of the problem in your respective institution. And then I would say the next thing to do is really to begin, as we talked about, examining your policies, even your clinical policy. Just as a quick example, I have a colleague that shared that in her hospital, the hospital where she works, they had a policy related to pain and restrictions on the dosing of narcotics. And that policy specifically excluded cancer patients, but it did not exclude patients with sickle cell. So we know that patients with sickle cell anemia, the majority of which are African-American, suffer severe pain. And as a result of being given narcotics from when they are babies, by the time they are adults, they need more medicine. It's not because they're addicts, it's because their body has tolerance. And yet, so these policies that, restrict pain medicine, that in that case exclude sickle cell, and that disproportionately impacts patients with chronic pain syndromes. So, things like that, just really looking at your clinical policies, your HR policies, and really examining them, as we talked about, with that equity lens, is going to be incredibly important. So with that, I'm going to pass the mic over to, let's see, we'll go to you, Dr. Gourdine. What advice or recommendations do you have for next steps?
So I totally agree with everything you said about data. I think that's so important, especially in healthcare, especially when talking to our healthcare providers, because we as doctors, we believe we treat everybody fairly and equally. I guarantee you, any doctor you walk up to will say, I absolutely treat everyone fairly. And so the way to engage in that conversation is with the data, and data down to the granular level. We do know that there are healthcare institutions across the country that don't all collect data by race and ethnicity. So Dr. Rochester, I agree with you. I want to offer something else that may seem very simplistic, but I think it's vitally important. We need to, in our workplaces and even in healthcare, begin to create spaces where it is safe to talk about race and to hear from those of us who have dealt with the impacts of race over our lifespan. You never know, quite frankly, when you bring up the issue of race, how people are going to take it. Some people may be receptive. Many people are defensive. Some people are violent. It shuts you down, which creates more trauma. I think that one way to learn and to make sure that the entire workplace is educated about the impacts of racism really can come from the employees who work within your workplace who have experienced it. When you think about physicians who are taking care of patients, we are literally taking care of patients, many of whose diseases are the result of racism in this country, while at the same time, we too are navigating that same racism. And so the ability to be able to have those uncomfortable conversations, for all of us to be able to sit in that discomfort, for people to have some insight, take the time to develop some insight into what those of us who have experienced racism are sharing with you, and then contemplate together what we can do going forward, I think is vitally important.
I completely agree. Thank you so much, Dr. Gourdine. You all, we have about 1 minute left. So Reverend Dr. Connor, I'm going to go to you, and then we're going to finish with Senator Washington with your closing thoughts, next steps. You're muted, Reverend Dr. Connor.
I concur with what everyone has already said here today. I really do like what Senator Washington said earlier, in addition to the facet we gave on the history, is that we've got to look at a lens, a racial equity lens, to make sure that what it is that we're doing, is it or is it not creating a racial perspective, a racial tension, traumatic experience for somebody. Take a time out, pause to assess and evaluate what you're doing and how you're doing and who you're doing it to.
Thank you so much. Senator Washington, you got to close this out.
I am. Thank you so much. And just to that last question, and to all the boards and directors and healthcare providers, the first thing you can do is look at your board of directors. While it's important to have an administrator who's of color, but look and see who your doctors are, who your board members are. So start right there. Start with doing what we did in the Senate, which was creating a work group on equity and inclusion, and looking internally about what it is to make your organization find out the ways in which you are perpetuating unknowingly or knowingly. Do more than just hire. Again, well, I think it's great for us to have consultants, and I'm glad people are getting work to do this work as consultants, but make sure that this is a person that is actually a part of your work group, that has hiring and firing ability, that has policy setting ability, and that is on par with everybody else who is part of your leadership team. Again, this is a great honor. This is a great session. I know it's an annual meeting. So I look forward to the progress that all of our healthcare providers and institutions are going to be making in the state of Maryland to close the racial disparities that we have in our state.
Well, I just want to thank all of you. This has been an amazing discussion. I definitely plan on following up with each of you. I think that, we're onto something here. So I want to thank you, and I want to thank the organizers of the State of Reform Conference for inviting us. And to those of you watching, have an amazing day. Go out and take some action. Thank you.
Thank you all. Good working with you all. Bye-bye.
Good working. Let's follow up. Let's make some good trouble.
Definitely.
Yes, please. Let's do.
Absolutely.
Let's do.